Thank you very much. My name is Souza. I'm a registered dietitian, postdoctoral fellow working with Sonia and Andrew, and I'll present to you today some of the evidence and lack of evidence for an association between saturated fat and a few health outcomes. So I entitled this Saturated Fat, Friend or Foe. So who would say saturated fat is a friend? Okay, one person. Who would say saturated fat is a foe? And many undecided. All right, so we'll see if I can convince you by the end of today, one way or the other, or not at all. So what is saturated fat? So saturated fat is a triglyceride that contains only saturated fatty acids. So if we look at a saturated fatty acid chain, you'll see that there are no double bonds. And an unsaturated fat has at least one double bond. So they differ in terms of shape and rigidity. So saturated fat is a very rigid molecule that is solid at room temperature, and an unsaturated fat is a fluid molecule that is liquid at room temperature. So the most common chain lengths that we see in our diet are carbon lengths of 12 to 18. So where do we find this and how do we consume it? Well, typically, according to the latest data, about 10% of Canadians' energy comes from saturated fat. So we typically get it from three major sources. One, our cooking methods, so the oils that we use to fry and bake, such as coconut oil and palm oil. We have saturated fat that is added to food, such as butter. And we also have foods themselves, which are rich in saturated fat. And different foods tend to be higher in different isomers of saturated fat, or different chain lengths. And as I was mentioning, the chain lengths 12 to 18 are the most common ones found in the foods that we eat. Now, you might have heard or read this article recently in the BMJ that said saturated fat is not the major issue for heart disease. And this was an opinion piece written by Asim Malhotra, who's a resident physician in the UK. And he came to the conclusion that it's time to bust the myth of the role of saturated fat in heart disease and wind back the harms of dietary advice that has contributed to obesity. So his premise of this article was to summarize the fact that much of what we have learned and put into practice about dietary fat, and saturated fat in particular, have actually been harmful for dietary goals, for the obesity epidemic, and for the cardiovascular disease epidemic. Now, as Sonia was mentioning, such a story is very sexy to the media. So we saw many reports in the popular press showing that, or suggesting that, okay, now it's okay to eat butter, not low-fat spreads, says heart specialist. A study now challenges conventional wisdom linking saturated fat and heart disease, not heart disease. And I just wanted to point out one key word here, and the key word here is study. So the article that the media reported on here was really an opinion piece. And when it gets translated into the popular press, all of a sudden an opinion piece can be called a study. Now furthermore, now it's called a paper that refutes saturated fat's role in CVD. Again, an opinion piece. And then finally, this one doctor in the UK writes an article, and all of a sudden all British doctors admit that saturated fats are not good for you. They're vital for good health, and they help lower cholesterol naturally without drugs. So one opinion piece blows up in the media to really give us quite the mixed message. So after reading all these in the paper, I wouldn't be, I probably want to eat saturated fat. Well, what do the professionals think of this article? So, of course, an article like this is bound to get a lot of responses in the academic press. So Peter Clifton, a scientist in Australia who's done a lot of work on fatty acids, claimed that this article did a disservice to the public debate on nutrition, ignoring some of the major roles of other nutrients in the cardiovascular disease picture. Alice Lichtenstein, who is also a member of the AHA Nutrition Committee, said that Malhotra missed a crucial point, and that is the displacement source of energy for saturated fat. So getting at two issues here. Saturated fat travels in bad company. It tends to travel with foods that are high in glycemic index, glycemic load, and also the choice of replacement nutrient for saturated fat. So if we get rid of saturated fat, what else should we eat? So 2 points that were really missed in the article are brought up. Now, where did the saturated fat hypothesis come from? So if we go back in the history of medicine, one of the most influential studies for diet and medicine was the 7 countries study. And the 7 countries study looked at rates of death and heart disease in 7, and in fact more countries, and attempted to associate risk factors and dietary risk factors with rates of mortality and CHD mortality. And probably the initial paper that launched the saturated fat hypothesis was the finding that serum total cholesterol was associated with CHD mortality, which probably is no surprise to anyone in this room. And furthermore, it was found that those countries reporting higher intakes of saturated fat from coconut oil and butter had higher serum cholesterol levels. So, next question, do these higher intakes of saturated fat, are they associated with higher CHD mortality rates? And indeed, we see a nice straight line here showing that increased saturated fat is associated with increased CHD mortality. Now, is this always the case? Now, later research showed important exceptions to the rule. So we see for the most part, when we graph the cholesterol to saturated fat index, which is a marker of both intake of saturated fat and cholesterol in the diet, we see for the most part a very strong association between higher intakes of cholesterol and saturated fat and deaths from CHD. However, we do point out two notable exceptions. Here we have France, which has a relatively high cholesterol saturated fat index, but a relatively low rate of coronary heart disease. And we have Finland, which has a very similar similar cholesterol to saturated fat intake as France, but has a much higher rate of CHD. So this was one of the early findings that suggests that there's more to the story than saturated fat. Now, randomized controlled trials have been done to look at the effect of different types of fat on blood lipids. So dietary fat is an important determinant of blood lipids, and saturated fat, it was shown to have the greatest total cholesterol and LDL cholesterol raising effect of any of the fatty acids. So many people took this as strong evidence that saturated fat in the diet should be reduced. However, one thing we'll see here is that the ratio of total cholesterol to HDL that did not rise in parallel with total and LDL cholesterol, and that's chiefly because saturated fat also raises HDL cholesterol. So perhaps the hypothesis that saturated fat raises LDL, ergo it raises rates of CHD, was a bit too simplistic. And in fact, if we look at specific types of saturated fat, which I talked about briefly earlier, lauric, myristeric, palmitic, and stearic, we see that for the most part, when these saturated fats replace carbohydrate in the diet, the ratio of total cholesterol to HDL actually goes down, which one would predict to be protective against heart disease. Now, despite all this, many government agencies still recommend reducing saturated fat in the diet. So we have the American Heart Association, the Heart and Stroke Foundation, the British Heart Foundation, and the Australian New Zealand Heart Foundations, all recommending reduced saturated fat intake. And I just wanted to highlight, most of them talk about the ability of saturated fat to raise blood cholesterol, LDL cholesterol. And again, also the World Heart Federation and also Dietitians of Canada and the American Dietetic Association, now called the Academy of Nutrition and Dietetics. So what has been the effect of this finding on your diets? So for the most part, fats, specifically saturated and trans fats, have gradually been removed from the food supply over the past 30 or 40 years. And for the most part, the replacement nutrient has been carbohydrate. So sometimes it's been good carbohydrate, but most of the time it's not. So we've seen low-fat ice cream, low-fat granola bars, low-fat Twinkies, low-fat cookies. So, does this conjure to you the image of a healthy diet that's low in fat? Who thinks these things are healthy? No. So I think the message now has gotten a bit diluted in that we tried to get rid of fat, but we didn't necessarily make the right replacement. So Sonia was talking earlier about the ability of a randomized trial to give us some answers. And one of the largest studies conducted of a low-fat diet and heart disease was the Women's Health Initiative. And this was a 9-year randomized controlled trial of almost 50,000 women that were randomized to either a low-fat diet or their usual diet. And it was presumed by targeting a reduction in total fat that the women would also reduce their saturated fat to 7%. Now, despite this, no specific information was given to participants on how to reduce saturated fat or trans fat or which substitutions they should make in their diet. So, just to give you a little bit about what happened over these 9 years, is that at baseline, the women were consuming roughly 38% total fat, energy from fat, and 13% of their diet was saturated fat. And the targets were 20 and 7%. Now we can see here that by the end of the study, or at least at the 6-year mark, people had reduced fat to 29% and saturated fat to 10%. So compared to what the investigators actually were trying to get, which was a contrast of 15% fat and 5% saturated fat, the actual contrasts were 8 and 3%. So the intervention for a long-term dietary intervention study was about half as effective as planned. And perhaps not surprisingly, this study showed no effect of a low-fat diet on MI, CHD death, or revascularization, or stroke. Now, why might this have been? Well, first of all, the most common explanation is that the participants assigned failed to meet the fat and saturated fat targets. But is it realistic to expect someone to adhere to one type of diet for a 9-year span? So as a result, this study was underpowered to detect their initial, they did not achieve the difference in fat intake that they had planned, so the study was left underpowered. They also found fewer heart disease cases than they were expecting. Secondly, as Sonia mentioned earlier, we had the issue of blinding. So people assigned to the usual diet may have altered their lifestyle in other ways. So they thought, okay, they weren't given the low-fat diet, so they thought maybe we'll do something else to improve our health. So this would lead to a lower than expected contrast between the healthy diet and the unhealthy diet. And then furthermore, other changes to the food supply were occurring in parallel during this time. And the chief one was a reduction in the amount of trans fats in the food supply. So we're looking at the period of 1993 to 2004, over which time the food supply in the US was gradually dwindling in terms of the amount of trans fats. So what this study taught a lot of us is that after $2 billion spent, a long-term dietary intervention trial of diet and CHD is not likely to provide definitive evidence. Now, PREDIMED did reverse this a little bit, and they were pretty effective. But I think that for a large portion of the diet disease hypotheses, randomized trials pose specific challenges. So we turn our attention to epidemiology. And I'll present to you some results that we found from a systematic review of saturated fat and all-cause mortality, CHD, type 2 diabetes, and ischemic stroke. So we searched the literature for observational studies that related saturated fat to any of our health outcomes. And the important thing here is that we looked at the frequency of outcomes, so not surrogate markers like cholesterol, actual disease events. So out of 16,000 abstracts that we screened, 33 provided useful information for comparisons. So I point out just one thing that I showed briefly earlier, is that in the 7 country studies, it was shown that higher percentage of energy from saturated fat was associated with increased all-cause mortality rates. However, subsequent studies that have also looked at this and that compared diets that were very high in saturated fat to diets that were lower in saturated fat found no association between higher intakes of saturated fat and risk of all-cause mortality. When we looked specifically at coronary heart disease, we saw a signal that increased saturated fat increased the risk of CHD, but this was not statistically significant. And if we look specifically at cardiovascular mortality, which includes death from stroke, we also see no effect of saturated fat on CVD mortality. And similarly, when we look at total CHD, so not only deaths, we see a non-significant increase in risk. And similarly, for ischemic stroke, we see no increased association of stroke with increased saturated fat. And then finally, when we look at type 2 diabetes again, we see no association between increased saturated fat and risk of type 2 diabetes. So what we found is that higher intakes of saturated fat were not associated with increased risks of mortality, heart disease, stroke, or type 2 diabetes. But there was a great deal of heterogeneity in our results. So some studies showed protection, some studies showed harm. So I'll just briefly end by going through a few of these reasons just to give you some food for thought. So probably the most important consideration when we examine this relationship is the choice of replacement nutrient. So when we try to get saturated fat out of the food supply or out of our diet, we have to replace it with something. So when we look at the food supply, sometimes this happened to be trans fat very early on before we realized it was harmful. But for a lot of people, and a lot of the more recent studies, this substitution was saturated fat for carbohydrate. Now, most carbohydrates that are eaten in the Western diet tend to be highly refined, highly processed carbohydrates. So the question that we ask is, if we replace saturated fat with a low-quality carbohydrate, refined grains, would we really expect to see a reduction in CHD risk? So one of the largest studies to look at the substitution question was something known as the pooling project, which pooled 11 major prospective cohort studies that measured diet using validated food frequency questionnaires, and they had a follow-up of about 4 to 10 years. And they observed 5,000 CHD events and about 2,000 deaths in 300,000 people. And what they showed here was that replacement of 5% of energy from saturated fat, so remove 5% and replace it with either monounsaturated fat or carbohydrate, and your risk of coronary event actually went up slightly, but replacement with polyunsaturated fat led to a reduced risk. And similar results were found for coronary death. And a recent meta-analysis that looked both at the effect of the predicted effect on cardiovascular disease risk based on changes in lipid risk factors and combined this with direct randomized trials as well as observational studies showed a similar pattern for polyunsaturated fat. So replacement of saturated with polyunsaturated had the strongest effect on CHD risk. Carbohydrate was relatively neutral, and monounsaturated fat was a bit divergent. So the message that we take away here is that the choice of carbohydrate or the choice of replacement nutrient is important. So higher glycemic index carbohydrates we think may be deleterious, leading to dyslipidemia, inflammation, endothelial dysfunction, and lower glycemic index carbohydrates may be beneficial. So this was studied directly in a prospective cohort of 53,000 men and women free of MI at baseline. And just to summarize in one slide, what they found is that replacement of saturated fat with either low or medium glycemic index carbs, so higher quality carbs, less refined carbs, were not associated with increased risk. However, when saturated fat was replaced with high glycemic index carbohydrates, processed and refined grains, they were associated with a 33% increased risk of MI. So another important consideration in studies of diet and disease is that of measurement error. So many of the tools that we have to measure diet today are imperfect, and Sonia pointed out some of the important limitations. One of the big ones being, if I ask you what you eat today, is that necessarily representative of what you've eaten your entire life? And few studies that we have of this association have used repeated, validated, and updated measures of diet. So when we're talking about very small changes in diet or very small risks associated with one dietary component, it's possible that these are missed. But I think it's important to note that several of the same studies that we use for this saturated fat analysis also showed very strong positive associations between trans fat and heart disease, which is very consistent with what we'd expect. Now we have the issue also of residual confounding. As Sonia was mentioning, people who eat high or low saturated fat diets may differ from individuals who do not in important ways. They may exercise more, they may smoke less. And finally, diet effects are relatively small. Relative risks for single dietary components may be as low as 10 or 15%, or even smaller. So the effect of confounding may be very important in diet disease studies. And finally, we can run into problems when we reduce a diet to its macronutrients. So people tend to eat foods, not nutrients. So if we recommend a diet that's, say, 7% in saturated fat, it becomes difficult to translate that into dietary advice for populations and individuals consuming diets. So importantly, saturated fat may not be the only component of a food that increases or decreases risk. So saturated fat is found mainly in meat products, and there may be other components of meat products, such as nitrites or something specific to animal protein, that may also increase cardiovascular risk. And then finally, as I tried to show earlier briefly, not all saturated fats behave the same. So certain isomers of saturated fat or certain chain lengths may have different effects on cardiovascular disease risk. But from a public health standpoint, it becomes very difficult to recommend specific saturated fats because they tend to cluster in the same foods. For example, hamburger may have all different types of saturated fats, so how do you specifically target one or more of these nutrients? So we need sort of very tightly controlled metabolic ward studies to enable to disentangle the effects of individual saturated fats, but it'll be very difficult to do this at a population level. Sorry, this just shows you the intercorrelation between types of saturated fats. So as you can see, most of them are very strongly correlated with one another. So I conclude with, do we need a paradigm shift? So for many years, we've been advising people to eat in accordance with certain macronutrient guidelines. But we don't eat nutrients, we eat foods. So I wonder if dietary patterns or lifestyle patterns might be a more efficient way, an effective way to get diet and lifestyle advice to a general population. And have interventions that are not only designed to target specific components of diet, but other components of lifestyle. So this might be an important way forward. So in conclusion, the reductionist approach to nutrition has limited the effectiveness of dietary advice to reduce chronic disease. People eat foods, not nutrients, and foods are complex exposures. And the effect of a single dietary component on a large problem such as CVD or even total mortality is likely to be very small and modified by a number of host and environmental factors. And one way that we may go in the future is towards dietary patterns and the role of entire diet and lifestyle choices. So that is our saturated fat story, and I'm happy to take any questions should you have. Thank you.